Good evening and welcome. I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Mel Wilkinson from the education team. Welcome everybody. A big shout out to our fellow Central Coast practices that are in the lockdown. I'm with you and we're all thinking of you, so hang in there. Just some housekeeping. We will, if you've got any questions at all, pop them in the chat box and we'll endeavour to get to those at the end of the session. If we run out of time, we'll answer them via email as well. So we encourage you to ask questions and engage. That's all part of this session as well. So pop those in the chat box and we'll get to them towards the end of the session. Also a reminder, we are being recorded tonight and this will be available in our education library. There's also going to be a survey poll and this is how we get our data and information back to plan further education events. So that's really important that we encourage you strongly to complete that. That data is really important to us and useful. So please complete the survey at the end of the session. It will pop up automatically. I've got tonight the lovely Alicia Southwell and Hannah Jenkins with us. Alicia has joined us from Headspace in the Maitland and Cessnock manager for operations of 4 core stream provisions, including mental health, physical health, drug and alcohol, and vocational support for young people in the age groups of 12 to 25. She's previously worked for the PHN and we missed her terribly in the primary care improvement portfolio and mental health commissioning teams in the youth, and a PCO for youth mental health and suicide prevention commissions coordinator for the Hunter, and she also worked with the Hunter Medicare Local, so that's quite some achievements there, Alicia, well done. Prior to us converting to the PHN. I'm going to now hand over to Hannah, who's one of our PCIOs, and I have to you, Hannah.
Thank you very much. I'll just kick off. So I'm going to start by briefly talking about the Better Access Initiative and referrals. Following this, Alicia will discuss where it is best to refer young people and what a step care approach means. She will then discuss how GPs can assist in service demand management, as currently there are long wait lists for a lot of services because there is a lot of demand at the moment. And finally, I'll briefly outline a quality improvement plan that you may wish to implement in your practice if you're interested in focusing on mental health. So I'm sure you are all familiar with the MBS billing available for mental health treatment plans, but I did want to highlight a few things. So when creating a treatment plan, and Alicia will mention this again, make sure to bill the appropriate number and not a time-based billing, as the specific treatment plan item numbers must be billed in order to trigger the Better Access Initiative. So the MBS descriptor also indicates that the mental health treatment plan should be reviewed at least once. With the latest changes to the telehealth item numbers, you are still able to review a treatment plan over the telephone. However, you can only create a plan face-to-face or via video conferencing. The changes to the telehealth billing also mean that you can continue to bill a mental health treatment plan consultation via the phone, not just face-to-face or over video conferencing. So additional and higher MBS rebates are available for GPs who complete additional training. So GPs can undertake training on focused psychological strategies. So this training provides education on specific mental health care management strategies. These are derived from evidence-based psychological therapies that have been shown to integrate the best research evidence of clinical effectiveness with general practice clinical expertise. So the General Practice Mental Health Standards Collaboration facilitates this training, and I've linked their training details on this slide, which you'll have access to. So if any GPs do complete the training, it is important to ensure that the collaboration has a record of your Medicare provider number. It's also worth noting that the MBS does state that all consultations conducted as part of a GP mental health treatment item must be rendered by the GP and include a personal attendance with the GP, with the patient. A specialist mental health nurse or allied health practitioner, Aboriginal and Torres Strait Islander health practitioner, or Aboriginal health worker with appropriate mental health qualifications can provide general assistance to GPs in the provision of mental health care. So I've linked the item descriptor there, and that includes all the information that you need to know. So once you get the slides, feel free to click into that and learn some more. So onto the Better Access Initiative, which provides a structured approach within which GPs can provide early intervention, assessment and management of people with mental disorders and refer to community-based mental health care providers. By preparing and billing a mental health care plan, you are unlocking a better health initiative for the patient. Eligible patients can receive up to 10 individual and 10 group allied mental health rebatable services per calendar year, but at the moment extra support is available until 30th of June 2022 for people who have a mental health treatment plan in place. So people experiencing severe or enduring mental health impacts from the COVID-19 pandemic can access an extra 10 sessions. So just a couple of facts. The World Health Organization has noted that stress, confusion and anger are commonplace as a result of the pandemic. And while many people may not experience any long-term consequences, COVID-19 has the potential to contribute to or exacerbate long-term mental illness, including anxiety, depression, PTSD and substance misuse. So the Australian Institute of Health and Welfare also reports that between the 16th of March 2020 and 25th of April 2021, over 15 million MBS subsidised mental health related services were processed. So there's a lot of demand out there at the moment. The initiative is important because people experiencing mental ill health, getting the right support and treatment strategies early is critical, especially given the current situation. So I'll hand over to Alicia.
Thank you. So I just wanted to talk about, thank you, Hannah, for going through the Better Access Initiative. But what we know that there is actually a bit of a process that's involved for both the GP and allied health providers. So we know that the Better Access Initiative it's available to improve treatment and management of mental illness within our community. And the aim is to provide patients with access to mental health service providers and a team-based mental health care. So under the initiative, the Medicare benefit schedule becomes available to patients or clients, as we say, young people, for selected mental health services that are generally provided by our GPs, non-VRs, MPs, psychiatrists, clinical psychologists, registered psychologists and appropriately trained social workers and occupational therapists. So services under the Better Access Initiative, they are actually different to the services that an eligible patient can access under the Chronic Disease Management Plan. And that's where I'll go through the 9 steps that are involved with our process. So first is the mental health care plan. So we know that the mental health care plan needs to be developed by the patient's primary or mainstream GP and is billed to Medicare using the MBS GP mental health item numbers, which Hannah has described just before. And what this does, by billing that item number like a 2715, that initiates the Better Access Initiative. So what we have found is that if a standard consultation is billed, not only is the costing and the billings different for the GP, but the patient, when they go to access and they've been referred to the mental health service, will not be able to claim that MBS bulk billing item number for the mental health service. So this is where it can incur out-of-pocket expenses, especially if a patient has been referred to a private psychology service or psychiatrist. So what we know is that once the GP bills that mental health care plan through the MBS, that's what initiates or activates that Better Access Initiative. So in terms of referrals from the GP to our allied mental health service providers, so like I mentioned, for patients to receive the Better Access Initiative or the MBS rebates, the GPs actually need to provide to the selected or the referring mental health service and service provider a valid referral. And the valid referral must contain clinical information, description, which this actually is description of the symptoms that they're experiencing, and it also can be the provisional diagnosis. With that, for the likes of Headspace, we can't our clinical psychologists and our social workers and those that deliver therapeutic counselling, We don't diagnose, and that's really important to have that information in the actual referral from the GP. The other important area of the referral is that the GP, we need the GP to write the number of sessions that's being referred for the course of treatment. And I know that, as mentioned before, through the Better Access, patients can actually access up to the 10 sessions per calendar year, and then with the COVID-19 mental health, additional mental health sessions that are available, they can access up to 20. But in the referral, this is where it is important that the number of sessions in that initial referral can only be up to 6 sessions. So even if a GP writes in the referral letter the number of sessions is 10, we as an allied mental health provider, part of best practice is that we can only see that client for up to 6 sessions, and then also the referral needs to be signed and dated by the GP. So as mentioned, the number of sessions. So the number of sessions stated within the GP referral is called the course of treatment. So whilst clients can access, like I was saying, up to the 10, that's per calendar year, so from January to December. It can include, once they've been utilised, the additional sessions, but once again, we need a new referral, which I'll go into a bit more detail in a minute. And then that's where I was saying that the GPs include that number of sessions. So the first would be up to 6 rebatable sessions at a time. Then we would get another referral letter from the GP to say a request for further sessions, which would be 4 rebatable sessions. So that then totals those 10 initial sessions that are accessible through the Better Access initiative. If a client or a patient does require the additional 10 sessions, that's where another referral letter will be required, and there is that right back and collaboration between our allied health mental health service provider and the GP. So we know in the initial course of mental health treatment for it to be complete, so that's where, like I was saying, with the number of sessions, upon the initial course of treatment, our allied health providers will always, and that's part of best practice, and it's a requirement that they write back to the GP, and with that write back, they'll advise of, the client's progress, any results of any tests if they've been undertaken. But again, like I mentioned before, they'll actually then recommend further course of treatment. And that's where our re-referral process comes in. So a new GP referral is required when a patient or a client commences an additional course of treatment within that mental health service and the provider. So once a course of treatment has been completed by the allied health provider, like I mentioned, they'll write back, but they'll also request that new referral letter. So for example, like at Headspace for our young people, no further appointments will actually be made for that young person until a new referral letter has been received. And that's so that young person can continue with the MBS billing item numbers and not be out of pocket with any expenses. And I suppose with that re-referral, like I mentioned before, so a re-referral would include up to 4 sessions. So it totals that 10 sessions availability through the MBS. And then again, once that's complete, the allied health provider will write back, and then there will be a request if they do require the additional 10. What was also important is with the re-referral, so it's not mandatory that when you do send a referral that you have attached a mental health care plan review. It's at the end of the day, the mental health providers, we just need that referral letter. So I know that as part of our governance with Headspace, we actually do ask when we first see a young person or a client, and this is probably for most of mental health services, when we do receive that GP referral, which that letter has to be separate from the mental health care plan, sending a mental health care plan does not suffice as a referral, and same with the mental health care plan review. We do ask that we have accompanied with that referral letter the mental health care plan. So we do ask for that as part of our governance, so we know that a young person has access to the Better Access Initiative, and then they continue to have that bulk billing service availability. In terms of expiry of referrals, so referrals and re-referrals, they're valid for the number of sessions that are specified in the GP referral letter. There is no date limit, and they expire when the number of sessions, so initially up to 6, and then the 4, and then the 10, so when they've been utilised and billed under Medicare. In saying that, if you do have a patient who has accessed all their sessions within that calendar year under the Better Access Initiative, that doesn't mean they stop accessing a psychologist. If it's a private psychologist, they can continue but they just can't access the rebatable, the rebate. So they will incur an out-of-pocket expense. I know for private psychology service and mental health services, sometimes there is that gap payment from the MBS item number to the private fee. So then there's the expiry of mental health care plans. And this is, I know, where there can be a little bit of confusion. So mental health care plans don't expire. What we know is that a mental health care plan can be completed by a GP if the patient's clinical picture has changed. But this is up to the discretion of the GP, being mindful that the mental health care plans can only be claimed under the MBS annually, and it's from when the mental health care plan was initially developed, and also a new mental health care plan cannot be claimed prior to the original mental health care plan date. And that's where you've got the use, and GPs can then also develop and bill for mental health care plan reviews, and that's where they come in place. So we know that once a mental health care plan has been developed, a patient can actually have a mental health care plan review undertaken within that 3-month period of that initial mental health care plan. And that's so the GP can also reassess just to make sure that the patient's clinical picture, if it's changed or not. So, and that's also ties in with if they've accessed their 6 sessions with a mental health service, the right back to the GP from the allied health provider. That's where the GP, we ask all our young people and our clients to come back to the GP to actually sit down and to undertake a mental health care plan review. That's if it's necessary, but also to have that collaboration. So there is that communication between us as the mental health referred provider and our GP. So GPs can undertake and bill the MBS, a mental health care plan review, like I was saying, with document changes, but I suppose a mental health care plan review is still part of the specific process within Better Access. So subsequent courses of mental health treatment. So best practice is for mental health providers to write back to the GP at the expiry of subsequent courses of treatment, so the number of sessions contained in the referral or re-referral. Like I was saying, if your patient or our client has completed all 20 rebatable sessions within the calendar year, they can continue to see a mental health provider, but they won't be able to claim further Better Access MBS item numbers until the next calendar year. So for example, if you referred us a client or referred a patient to us and we saw them in, say, April, then again it carries over, so it would be April the following year. That's when it would click in that they are able to access the addition, like the next set of mental health item numbers or under the Better Access Initiative. And of importance too is discharge. So the final process is where the allied health provider, and this is best practice, service providers are required to write back to the GP, and especially the GP who referred, and advise of the completion of mental health treatment, or if they've been discharged from the mental health service. So yeah, I just wanted to go over this process because better access isn't just, I know a lot of it is about accessing the MBS item numbers and making and rebatable costs, but there is a process, and of importance, it's really about that collaboration between the GP referring to the mental health service provider, but also the service providers writing back and keeping that communication and reviewing of what's happening with the patient and the young person or the client, just making sure that their needs are being met and there is that reassessment each time. So with the better access, the Department of Health has also developed, it's called a stepped care approach for mental health. And I suppose, what is the stepped care approach? So we know it's been defined as an evidence-based, it's a stage system comprising of a hierarchy of interventions. And the interventions are from the least to the most intensive, which can be matched against the individual's or your patient's needs. So this approach promotes person-centered care and care that targets the needs of the individual. So rather than offering a one-size-fits-all approach to care, individuals will more likely receive a service which is more optimally matches their needs. It doesn't under or over-service them, and it makes the best use of the workforce and technology. So looking at the stepped care approach, this provides the right service at the right time with low intensity steps available to support individuals before their mental illness manifests. So with the diagram, you can see that there is the 5 levels with this stepped care approach. So if I start at the bottom and I look at level 1, so self-management, so we know this service is designed to prevent the onset of mental illness or prevent further escalation, and it's focused on supporting symptoms around self-management. So this is where GPs can also help in saying that before, like with service demand management. So this is where also, like, you GPs, not only are you doing the mental health care plan and the reviewing, but if they know that they've referred a patient to a service and there's a longer wait list, or their service demand, the demand management of the service is quite high, the GP can actually get that person back, and that's where you can use your mental health consultations and the item numbers that are billable through your practice there. And that's really important. So the next step is to your level 2. So this is a low intensity service. So they're being designed to be accessed quickly. They're a service where you don't need a formal referral, and there's with the service, there's a range of modalities, and they more or less involve few to short sessions. So it's not a long-term approach to with their mental health needs being met and so forth. Then we've got your, say, level 3, which is your moderate, mild to moderate intensity services. So this is where the level 3 is structured to look at more reasonably frequent and intense interventions. So if I'm looking in the sense of our headspace service, we're a mild to moderate service for mental health. So that's where we actually engage with that level 1, level 2, and level 3. We work with, getting into community to prevent the onset of mental illness. And we also then have our mental health service providers who assist with, they don't need to have, or young people who access our service don't necessarily always have to have a formal referral. you know, they can self-refer, their parents, family carers can refer, community services can refer, as well as majority of our referrals do come from GPs. But once they start to work through the service and they get assessed for what requirements are needed for their mental health, that's where we always, part of our clinical practice is to contact the GP to get a referral letter from the GP so we can access that Better Access initiative and their mental health care plan, so we can see if there's been a diagnosis and what's needed for that young person. The next level we have is level 4. So this is our high intensity service, and this includes periods of intense intervention that may involve multidisciplinary support. And then we've got our level 5, where that's our intensive team-based specialist assessment and intervention. So that's looking at, you're sitting at your acute care, so the likes of our child and adolescent mental health services. We've got, if it's adult mental health, then I know, like in my region, so the lower Upper Hunter, there's the Hunter Valley Mental Health Services. So that's our level 5, so the LHD, typically our state and territory mental health services. And those services actually involve a different range of mental health professionals, and that includes case managers, psychiatrists, allied health workers, and GPs. So to look at that diagram, a really easy, clear way, and I'll use Headspace and our youth portfolio, is that you've got our GPs, Headspace is our level 1, 2, and 3, and then our level 4. So that's where I'm not sure if you're familiar with, but we've got our youth complex mental health services. So I know across our PHN region, we do have youth complex mental health, so there's different programs. So for example, in the lower Hunter, more Cessnock through to the Upper Hunter, we have our Rural Young Minds program. So that program fills the gap for those that, you know, if there's young people who don't meet the criteria for Headspace, but they don't quite meet the criteria for acute services with our LHD or CAMS or Hunter Valley Mental Health Services. So that's where youth complex services like the RIMS program. I know in Newcastle there's Headspace Extra, there's youth complex services in the Central Coast as well as the New England. So probably the best way to have a look at that is to go into health pathways, and that's the uniqueness of our health pathways, is that this stepped care is actually embedded into looking at what services are where, and it actually triages, so it has the different levels of urgency and the criteria against each of these levels. So the other thing of importance is that with this stepped care approach, so I know I've spoken a lot about mental health services, but the role of the GP is actually crucial. So we know that GPs are the first point of clinical contact for people seeking help for their mental health problems and mental health issues. And I suppose in a little way, you know, you guys are the gatekeepers of other service providers for our mental health, because it's you guys that you're the first contact, and generally, you know, you're referring to mental health services and programs that can help your patients. So in more, I suppose, of, you know, what's the role of the GP in your stepped care? So this is where, you know, GP counselling, like I mentioned before, so it's not, you've got your mental health care plans and you've got your mental health care plan reviews, but your GPs can also counsel patients without the structure of formal psychological therapy. And this can really help in terms of that service demand management, or if you know that you've got patients on wait lists. So, you know, checking in, you know, having your patients come back and book in like your recall reminder system just to get them back in to see how they're going, and that's where you can utilize your mental health consultation and those item numbers relating to that. Also, our GPs, you know, you can refer to your digital mental health treatment programs and platforms, and there is a lot out there. There's a lot that's been developed by the Black Dog Institute. Also with Beyond Blue, there's MindSpot, there's EveryMind. A really great resource that I know is the mental health in practice, so MPRAC, which is just down the little corner there. I've got the logo. So I strongly encourage to go and have a look at that as well, because there's so much in there in terms of it's got links to the digital platforms, it's got different resources from all different mental health organizations that you can access, and it can be really helpful. The other platform I know we have with Headspace is eHeadspace. So that's a platform, you know, if it's that level 1 of the stepped care approach that young people 12 to 25 can access as well. And I also strongly encourage, and like I mentioned before, is our health pathways. There's so many referral pathways in there, and there has been a real focus with the mental health services. And I know that some of our Headspace providers like ourselves and Newcastle are actually involved now and accepting electronic referrals via Sent. So you guys are already sending out your Sent e-referrals electronically to the LHD and other services, and we're now accepting that through Headspace as well, which is really exciting. So depending on the, I suppose, appropriate level of training that your GPs have undertaken for mental health, GPs can also deliver the face-to-face focused psychological therapy. So things like with your CBT therapy, and then your therapeutic counselling and things like that as well. And the main, generally the main referrers to allied health professionals such as psychologists, occupational therapists, social workers, or specialist psychiatry services. And that all again comes through that GP mental health treatment plan, because that's where the GP will outline what services they would like to be involved with your patients. Other importance is, I suppose, your GPs, they support access to disability services. So I know a big thing at the moment, and it has been for a while, is, you know, the NDIS, and now mental health services are involved with the NDIS as well. And then you've also got the engagement with families and carers, and, you know, your community, which is really helpful for our allied health providers as well. So I know that I'm speaking, I'm not going into the real heavy clinical side of things in terms of just trying to tailor this with, I know we have quite a few practice managers with us this evening, but in terms of clinical, I just do want to touch base with referrals, and I suppose just having a little understanding, like with that stepped care model, about the use of, like, I know for youth mental health and a lot of our psychology or allied health mental health services, is that the K10. So the K10 is actually the Kessler psychological distress scale. It's a 10-item questionnaire that's intended to obtain or yield a global measure of distress based on questions around anxiety and depression symptoms that a person is experiencing and has experienced in the past 4 weeks. And that's where this is where it's really important with GPs in what services that you're referring to. So like I mentioned before, so in looking at the K10 score, and this is where the K10 assessment tool can be used alongside with the mental health care plan and development, is that when a client or a young person has a score, or even a patient, from 0 to 35, that referral would be best suited for our low, mild to moderate intensive services. So that's our level 1, 2, and 3 of the stepped care approach. And with that, like I mentioned before, you would be referring to Headspace. So if you're looking at the scores, if there's scores that are higher from, say, between 35 to 45 with the K10, that's where that your patients would need more of a high intensity service. So that's where I've got our Rural Young Minds program. So even though what we are finding, because Headspace is a low to mild to moderate service, is that we do receive referrals that have K10 scores that are probably best in terms of criteria, could have and should have been referred to the next step up, which is that high intensity service, so like the youth complex mental health service. And then for a K10 score of say 45 to 50, that's where a referral, should be made to the acute and specialist mental health services. So that's like, I mentioned before, the child and adolescent mental health service or Hunter Valley mental health service, even the Calvary Mater and things like that. But if GPs aren't sure, if they get a score where it is high, it could be sitting around the high intensity or the acute specialist mental health service score, they can refer to the mental health line, and that's where they'll assess as well, and then refer on that patient to the most appropriate service. So generally what we mean by say acute and specialist mental health is that, say for example, and I keep referring back to Headspace, but if there's a young person that's coming that attends our service, they've got thoughts of suicide, or they're hearing voices, they're self-harming, that's a referral that should have been, or is best to be passed on to our acute specialist mental health services. And that's where our clinical team assesses that, and then they will always refer on that young person to the best service that's needed, and they'll contact the mental health line. So just a bit more information, I suppose, in terms of like our youth complex mental health service and like our Rural Young Minds, is that that's a program. So again, it is for young people aged 12 to 25 that have complex to severe mental health concerns. So I know it's the missing middle from our low, mild to moderate intensive services to our acute care. I know for, like I mentioned before, Rural Young Minds, it is located and specific to certain LGAs. So I know with Rural Young Minds, they look after young people that are located in Muswellbrook, the Upper Hunter, Liverpool Plains, Cessnock, Singleton, Dungog, and the Mid-North Coast. And then you've got like your Headspace Extra, which also, that's a youth complex service that is managed by Hunter Primary Care, and that looks after your Newcastle, Lake Macquarie, Raymond Terrace, that region's there. And then again, there is the youth complex services that are located up in our New England, Tamworth, Armidale, that region, and then the same with the Central Coast. So that's linked in with the local health district down there. So I know, like I suppose looking at referring to Headspace, and like mentioned before, so we are a low to moderate intensive service, but this is where I find it's really, you can understand the inclusion criteria that we have for Headspace as well as the exclusion. So in terms of, and this is where the K10 scores do come in hand, like they do help in the assessment process of this. So for inclusion for our Headspace service, so it's for any young person who's experienced like or at risk of mild to moderate mental health difficulties. So that could be anxiety, it could be depression. And if the young person's suitable for short to medium long-term intervention. So for us, and like I mentioned before, it's young people accessing generally up to the 10 sessions for mental health services. The reason we say up to 10 sessions is that because we are that low to mild to moderate intensive service, if a young person requires more than 10 sessions, generally that's where we sit down and we will involve the GP, and we would write back to explain that possibly that young person actually needs to be stepped up to the more high intensity service based on their need. They need long-term support, where Headspace, we're more that short, medium term intervention. There's at least a 6-week period of that's the thing, there has to be at least 6 weeks of no suicide attempts or serious self-harm, as well as an absence of intent to act on thoughts of suicide at the date of the referral. So that criteria, if you do have someone that is experiencing that, that's where they actually need to be stepped up into that high intensity and that acute care. So and again, that's where that K10 and the assessment tools help you GPs to assess that as well. We also, our inclusion criteria includes presenting issues. So, you know, if you've got young people that are being bullied, they've got interpersonal issues, family issues, relationship breakdown, there's adjustment disorder, stress, grief, loss. As mentioned before, we're seeing with COVID and the impact COVID's having. So we are starting to see a lot more distress among you know, our community and young people, as well as we, you know, if there's people that have some drug and alcohol issues, that's part of our inclusion criteria as well. So looking at exclusion, so again, it's that risk, and pretty much at the end of the day, a bit of the philosophy is if you're unable to conduct a safety plan for someone, then they're high risk. They're not suitable for that low to moderate intensive service. They need to be stepped up to that high or that acute service as well. Exclusion criteria also, like I mentioned, is that moderate to severe OCD. Same with eating disorders, specific to anorexia nervosa. Same if there's any diagnosis of schizophrenia, psychosis, sexual assault. So we are seeing a lot more of that among young people, unfortunately, and same with domestic violence, and as well as if there's complex child protection concerns requiring a multi-agency coordination. So being with Headspace, we are mandatory reporters, so we do report if there are any child protection concerns. So that's really important just to understand, I suppose, that inclusion to exclusion of criteria for Headspace. But in saying that, we never turn away young people. That's where we have our clinical processes that our intake team who are early intervention mental health clinicians, and we also have our clinical leads. So they also collaborate with our acute services like CAMS and Hunter Valley Mental Health or Calvary Mater and that type of thing. So wherever that young person's accessing. So like I mentioned before, excitingly, we, Headspace Maitland and Cessnock, I know Headspace Newcastle, you can now send electronically. Before, I know for us at Headspace Maitland, Headspace Cessnock, is that you could use the Send e-referral tool, which is embedded in your clinical software. But when the GP would go to submit, it would say to print out a paper copy. And then a lot of our GP practices would send to us the referral using fax, and so go fax, so we get that email. Excitingly, we've been working with the K10 and the digital health team, and we've been collaborating with they have been too, with all mental health commission services, and it's now part of the K10 or our contract obligation that we are engaged, and we're starting to move with that digital health strategic plan that's also been developed by the Department of Health. So with that, it's been great to see that we've been getting our referrals that are coming in. Unfortunately, with the GoFax and with the referral process that way, we do tend to have a lot of missing information, and that's just through that product of GoFax. So there tends to be that toing and froing of us contacting you guys to resend that referral, which can be really clunky for both you guys and for us in terms of time that as well. So this is where you can now send to your referrals to us using Send e-referrals. In this diagram, you can see when you go in and actually select, the GP can triage and so forth, but there is a hover that will come up that would say that, you know, Headspace is a service for young people 12 to 25, and that of importance, like I mentioned before, about the number of sessions, you can go in, and this is what we're starting to see, is that there is a section in, don't mind me, it's just a bit further, it's got standard clinical information. So there's another section that you can add 5,000 characters, and that's in the clinical information. So that's where the GP can actually write the diagnosis for that young person, what symptoms they're experiencing. It could be even their K10 score, but then they would also write the number of sessions required for our allied health providers to, our mental health service providers to see that young person. And the other great thing about this tool is that you can actually attach that mental health care plan. So what we're finding is that the referrals, we've been live for the last 4 weeks, is that we're starting to get that streamline of information. It's consistent in the information coming through, and as well you can attach that mental health care plan. So it has been a work in progress, but yeah, like I really strongly encourage to continue that, to refer that to us as well. What I do know is that majority of our GP practices are now live with Sent, and that, you know, there's referrals that it gets sent to our local health district, to the programs and services, as well as you can use your Sent e-referrals to private allied health providers and providers too. So yeah, at the end point, how we receive the referral is that we get an email notification to say that we have a referral that's been sent to us from a GP that's actually sitting in the referral manager portal that we use a username, password to log into. So it's all really secure compared to what we were having before with our GoFax.
Awesome. Thank you, Alicia.
And
Is that
now
everything?
I'll hand over to Hannah. Thank you. Yeah.
Thank you. So if you do have any questions about Sent e-referral, you can get in touch with your PCIO and our digital health team, and we're always more than happy to help you out with that. So in terms of quality improvement, if you wanted to focus on mental health for your quality improvement activities for, you know, your QI, PIP, or for accreditation, there are a few ways that you can keep track and monitor the data specifically in relation to mental health. So the PHN creates general practice comprehensive dashboards using the de-identified data that is submitted for the quality improvement PIP. And there are a few mental health specific measures that we include in the report. The first is indicated mental health with no diagnosis, and that is the graph on the left. Here the software picks up on things that are things such as medication that is prescribed, or whether they have a mental health item number billed. If the patient does not have a coded diagnosis that is recognised by the software, it will flag as an indicated mental health with no diagnosis. I've linked instructions from PenCS, the website, on the slide, so you're more than welcome to go in there and find out how to run that report. The second measure that is included in the report is mental health billing. So it looks at the number of mental health treatment plans, the reviews and mental health consultations that have been billed. So PenCS has updated the algorithm so that the temporary telehealth item numbers for mental health are included. So the report you can access is pretty accurate. It is always interesting to look at the number of mental health treatment plans compared to the number of mental health treatment plan reviews and consults. So as Alicia mentioned before, there is some wait times associated with seeing a psychologist. So being able to bill a phone call mental health consult might be a useful way to touch base with patients while they are waiting to see a psychologist. Another thing I wanted to touch on briefly as a way to get more data or more mental health data is a lumos. So lumos is a collaboration between the PHNs and the New South Wales Ministry of Health to assist practices gain a stronger understanding of their patients' journey throughout the health system. So it's an approved program that securely links data across primary, ambulatory and acute care. So reports are produced 6 monthly, and they reveal your patient's interaction with the tertiary healthcare system. It is all de-identified. Each report they practice can receive has a condition in focus, and the latest was mental health. So the latest report included data from the early stages of the pandemic, and it was amazing to see an increase in the number of patients being diagnosed with a chronic mental health condition. If you are interested in receiving a lumos report and signing up, it is free. Just get in touch with your PCIO. So in terms of running a QI activity for mental health, this is an example you might want to run through. So we've created a mental health quality improvement toolkit that is available on our website. And one of the ways to start looking at mental health is to do some data cleansing in your records and increasing the proportion of patients who have a mental health diagnosis that's recognised by the Cat4 software. Without an accurate diagnosis in the software, it's hard to draw meaningful data. So that is a screenshot of what the model of improvement may look like. And that may be what a PDSA cycle might look like using the Cat4 software to identify all patients who have a mental health diagnosis that's not being picked up by the system. So that's referring back to that indicated mental health diagnosis before. So one suggestion is, using the report to print off, say, 10 names for a GP to review, giving them time to review and make the necessary changes in best practice or medical software or whatever medical software you're using. We have these templates and examples on our website, so please don't hesitate to get in touch with your PCIO to access those, or just head over to our website whenever it is convenient to you. So that's the end of the session tonight. Thank you for joining us this evening. I'm not sure if there are any questions, but if you do have any questions, please put them in the chat box. I will also just mention that the PHN is supporting general practice staff by offering up to 3 free counselling sessions as part of our member assistance program. That is completely confidential, so please access that number if you need to. And always, as Alicia mentioned, refer to Health Pathways for up-to-date clinical information. Mel, I'm not sure if there's any questions.
Thanks, Hannah. We've just got one about services for GPs. Localised services that GPs can refer to Alicia. How did they find out where they're located and things like that, how to access them?
Yeah, look, I think the easiest way to do it is to go into your health pathways and to use a search engine. So if you type in mental health, there's a drop-down box and it has so many different say pathways for what's needed. So I know I mentioned before about suicide ideality. There's also that level of that stepped care intensity, different types of services. So if you need private psychologists, that's in your health pathways. Headspace, same with adult mental health services, they're in there as well, and the different programs too. So I know, like for aftercare, there's quite a few aftercare programs, so that's more for following on from acute services. So if there has been an attempt of suicide, there's aftercare programs that have been commissioned through for Lifeline. There's the Wayback service. So they're programs that are psychosocial support services that can be accessed for your patients and that as well. So the best place to be would be through your health pathways, because there are a lot of services out there and it's getting familiar with your local area of what's needed. So I would say, yeah, go into the search engine, have a look, and if you've got questions too, don't be afraid to pick up the phone and actually contact different services as well. I know our clinical leads always open, and myself, to have that discussion, to ask what service, what do you offer, is this the right fit for your patients? And same with your GPs, if they're not 100% sure, get on the phone and communicate, and we collaborate and work together. That's really important.
Okay, fantastic. Thank you both.
Thank
that
you.
seems to be all the questions that's come through. I think you've covered it all. And if anyone thinks of any further questions and they'd like to send them through to education@thephn.com.au, and we'll get Alicia and Hannah to reply to those for you. Thank you, Hannah. Thank you, Alicia, for this evening. That was a really great session and very timely at this time. So thank you so much. Just a reminder to everyone, please complete the survey poll, and that is recorded, and a copy of the presentation will be up on the website in the next 24 hours. So So I thank you all for being here tonight. Have a lovely evening, and we'll talk to you soon. Thanks.
Thank you. All right.
Thank you very much.
Bye.